I've done the 2 years every month.
Right.
And I hear sometimes to do every 2 months, and sometimes I hear every 3 months for the next. And then I read one place, I just read one recently where they said something about going from Zolita to Iridia to make the change sometimes.
Okay, so, I mean, that's a good question. The question is, how long you take these medicines that are important to protect your bones. There's two drugs, Zometa and Iridia. Zometa is more potent, so you give a smaller amount. When they compared them head to head, it didn't make a huge difference which one you used. I still believe Zometa is more effective than Iridia, but by the time that you had enough of it, both of them get in there. The studies that were done with Zometa went for 2 years, and then the study was over. So the problem is there are not many studies beyond that. We did the study giving Zometa after that every 3 months. And we would follow how people were doing. And it seemed like if there was a urine test we would measure, and if that was okay, every 3 months was fine. So that's what I tend to do every 3 months, Zometa after 2 years. The problem with these drugs is they do build up. So the dose that you had 2 years ago a lot of that is still in there. So the most important thing is getting it in to get it started. That first year of treatment is really important. The problem is that it does build up, and if it builds up a lot, it makes it hard for your body to heal bone that gets infected, which usually happens in the jaw. My humerus it's hard to ever get it infected because it's buried deep inside my body. But my teeth go straight into the bone, and my mouth isn't necessarily sterile. So the bacteria can track down the roots of the tooth into the bone and infect the bone. And the way your body gets rid of an infected bone is to dissolve it. And Zometa and Iridia prevent your body from dissolving bone, so it makes it hard for it to fix the infections. I don't think you ever need to switch from Zometa to Iridia or Iridia to Zometa. You can stick with whichever one you're on. Sometimes that's where insurance companies, unfortunately, play a role, telling you which one you have to use or not. I think they're equivalent, based for all intents and purposes. I think you have to use, everybody's myeloma is a little different too, and everybody's health of their teeth is a little different. So on one end is somebody, like I heard about just a few minutes ago, where their bones are really in trouble with the myeloma. It attacked their bones and they lost a lot of height and they're in pain. Well, that person needs those drugs for their bones a lot. So I would give more, I would at least do the 2 years and continue giving the bisphosphonate for sure. There's other people that even when they had active myeloma, their bones were fine. Well, I still like to give the 2 years of the bisphosphonate in many cases, but certainly for that person, they don't need so much. And maybe, especially if they had bad teeth, I'm more worried about that infection I need to get in there. So you have to look at how the myeloma behaves. And you won't get a right answer because there is no right answer. This is debated all the time and research made on it. Dr. Berenson, who many of you go to, he tends to use more Zometa than others. But I understand his rationale. I mean, having broken bones is a bad thing.
So the Zometa doesn't fill in the holes though, right? It just strengthens the bone that's left.
No, it doesn't fill in the holes, but if you ever looked at a disc brake have holes in them and they seem to be just fine. So you won't fill in the hole. The x-ray can look terrible. But if the around part is stronger, you're not going to break. So to make the x-ray perfect is impossible. But to make the bone strong enough to not break. That's usually what happens. A lot of times, I've had people back in the old days when we would give Zometa or Iridia every month forever. There's one gentleman I couldn't do a bone marrow biopsy on because his bone was harder than my needle. So I couldn't, or at least it was harder than my arm. I couldn't put the needle in. So, you know, that, it can be pretty strong.
Does it also affect kidney or anything, side effects with the...
Yeah, it does. So they can hurt the kidneys. That seems to be more related to how fast they're given. So when they gave it to mice, the mice, if you gave it faster than 1 milligram per minute, the mouse's kidneys would get damaged. So when Iridia came out, it was 90 milligrams over, well, they figured we don't want to cut it too close, 90 minutes, so let's do 120 minutes, 2 hours. And people, despite that, pushed the envelope. And I've been around the country long enough and seen doctors and, you know, patients would get Iridia over an hour. And they would do fine for a while, but eventually their kidneys would be injured. The same with Zometa. Zometa's 4 milligrams. So you'd figure, well, we better take 5 minutes to give it. Well, 5 minutes was just a little too close. And 5 minutes it would hurt the kidneys. But that's why you have to give it over at least 15 minutes. And I tend to write for it at over 30 minutes because by the time you get to the chair and sit down and open a book, whatever, 15 versus 30 minutes doesn't make much difference, but it might make a difference on the kidneys. So you just have to give it slowly enough. You want to be hydrated. So the double whammy would be to get it fast and to get it, you know, after you had a bunch of diarrhea and were dehydrated. That's when it really can hurt the kidney. And fortunately, it seems like if the kidneys start to get harmed, if you take a break from it, then the kidneys recover in most cases.
With regard to Velcade, I had a reaction to Velcade, but not on the first shot, on the second shot. Was there any way to theoretically anticipate this?
What was the reaction?
Nausea, diarrhea, throwing up for 10 days, lightheaded,
Really?
and lost 50 pounds. Needless to say, I was taken off.
Yeah, well, sometimes, here's what I've noticed. Sometimes people have a bad reaction, and it may not even have been the drug. So some of the best advice I've given to people a long time ago and over my career is somebody took, and I'm not saying this is for you, but sometimes people took a medicine and they had a reaction, and they said, I can't take that drug. And it's the drug, it's an important drug. And we got 5 weapons, let's say, for myeloma, and if 2 aren't working, then, you know, one of them you say you can't take. I want to make sure that drug really can't be taken. So I've re-challenged, and they've done fine.
Well, I did try it again 2 months later, and
Had
the
the
exact
same
same
thing?
reaction.
Yeah, well, then that's how you know, and then
Well,
for
now-
you, you're extra sensitive, extra
I'm on
sensitive.
Carolus, and I've had no side effect.
Yeah, I think Kyprolis is better tolerated on average. But
But they work similarly and are both effective.
they work on the same thing inside the cell, so presumably they work similarly. But it is a dose. I don't know that anybody knows exactly, and it's probably not perfect this way. Does 27 milligrams of Kyprolis equal, you know, 1.3 milligrams of Velcade? Nobody has it down to that type of analysis. So, yeah.
Well, both actually dropped my M protein 22%.
Some of the time, what I've noticed is the people that have side effects from the medicine, often it's because the drug works. So the people that have dramatic responses to Velcade are often the ones that then 4 months later are coming in complaining of neuropathy.
You know that fish test? I think it's called a fish test. I think think I have one gentleman I was initially diagnosed, and I just want to know, like, I haven't had one done ever since. If I were to take one, if you're oral or whatever, would that change? Could that change into something like a deletion 13 or something?
Generally, yeah, that's a great question. Generally not. So that's why it's more important to do it on the first one. It's like the definition of the clone. There can be minor changes, but usually the main ones that they're looking for basically stay the same. So people that had 17p deletion, 414 translocation, when the myeloma cells come back, they will have those still. People that didn't have it, usually when it comes back, they won't all of a sudden have it.
Thank you.
I'll go like that.
Could you speak to smoldering myeloma?
So smoldering myeloma is an area that people are very interested right now in what to do. 10 years ago, or maybe 15 years ago, there was a study giving melphalan to people with, and steroids to people with smoldering myeloma versus waiting. And there was no advantage to treating it with melphalan. And the melphalan can cause some, in occasional patients, its own problems. So, it was decided back then not to treat people who had smoldering myeloma with drugs to kill the myeloma cells. Now we have drugs that are a little better tolerated than melphalan. So it raises the concept of maybe trying now with some of these newer drugs. And the drug that's the most convenient is a pill rather than a shot. So people have tried doing Revlimid as maybe a treatment initially. And there's one study being done in Europe, and so far it does show an advantage to treating smoldering myeloma, but the problem is the people that were watched are doing terribly. I mean, the people that had smoldering disease that were just observed with no treatment, a third of them have died in 3 years, which isn't very good. And you have people with smoldering myeloma, since a third of them didn't even need treatment, never had myeloma growth. So it's hard to die of myeloma if it's not even. So it just seemed like the patients did terribly, the ones that were just observed. So the people that were treated with Revlimid did pretty well. So it's an area that, there's a study ongoing. It seems to be hard. It seems to be hard to believe in its results so far. So we're left with this. We don't know what to do. In the meantime, one thought is to protect the bones, because myeloma can hurt the bones. So usually I would suggest, I think most people would suggest, getting something for the bones if there's any sign that the bones are being injured. So a bone density test, make sure the bones, there's no osteoporosis. And then the key is just watching the protein spikes. If they're growing, then at some point it's probably worth doing the treatment. If it's staying perfectly the same, I mean, it's, one advantage of waiting is 3 years from now we'll have better treatment than we have today. So if you can wait 3 years, we'll have better treatment. And so you can start off with a better treatment rather than starting off with the treatment we have today. That's the advantage to waiting. I don't know. It's I get very nervous watching people with smoldering myeloma, because I think everybody's always wondering whether it should be good to treat sooner rather than later.
I'm afraid after having perfect teeth my whole life, like 7 fillings my whole life, 2 days ago my dentist said, Mr. Crackon, the chemo drugs and dry mouth have totally withered away your teeth, and it's literally affecting at least 6 of your root canals. So we're going to have to pull some teeth. I just want to express that that's a side effect that you need to maybe look at. I don't know what we can do. He said you could have brushed your teeth 4 times a day and used biotin, and it may have helped a little. But really, the chemicals of so strong that your teeth are getting eaten away. And if we don't do something now, I'm not sure exactly what he said, but in about a year, you're gonna start having some real problems. I don't know if it was abscess or it almost acted like something was gonna explode, but maybe that was a figurative thing for, big problems. And of course, dealing with the teeth in our bones is something that we have to look at.
I think it seems, and again, it's hard for me to judge because everybody I'm seeing has multiple myeloma or something related to it, so it's hard for me to tell what happens. I don't have a good comparison group, but it does. I think the drugs that people take for this, I think it probably does suppress the saliva that's being produced, and without the saliva being produced, that's not as, the teeth get damaged more easily, more quickly. I don't know what the solution is. I don't know. Maybe the dentist will have something to say that can be done to keep people from having this problem. Not everybody has it. I have people that have, they look like they get the movie star teeth, so somehow they lucked out. But, yeah, I think you're right. It seems like people with multiple myeloma have more dental problems than I would have predicted people should have.
Okay, one more question, if you may know the answer. It's kind of a biggie. Is my medical insurance going to cover this, or is this a completely separate dental thing I have to do myself? Because I don't have dental insurance.
Right. I don't know, but I doubt it's going to cover things, but I don't know. That's a good question. Maybe it might be best to have people document that. I don't know how it works.
Oh.
But maybe, yeah, if you can have something documented that this was a side effect of the treatment, then maybe yeah. And it sounds like it was, so that might be a good thing to have somebody document it somewhere.
Nobody has heard anything about this. Nobody?
Go ahead.
After I had a lot of my heavy-duty chemo and everything in the beginning, I went to the dentist and they wanted to pull us 5 crowns off because they said that because of the dry mouth, the bacteria had stayed on the gums, and so it had gone up under the crowns. And I haven't found any way so far that I could be covered by my insurance because I don't have dental. But there is a mouthwash called Paradex.
Right.
And that might, I've used that. That might help relieve some of the bacteria or something.
Yeah, it
But,
kills the bacteria.
and then my dentist told me to use, it's prescription fluoride toothpaste that you don't rinse it off at the end when you leave it on your gums overnight, and you brush with it, but then you just kind of leave it on the gums overnight. But I don't, I'm just living with it. My teeth hurt, but then I also know the Zomita stuff too, so.
Yeah, I think it's, I think it's good. It's having a good dentist is important if you have myeloma. And there's some that are very knowledgeable and some, just like in every other field, not so much. So having somebody to give you some good advice, and it is important to do the best you can, but I don't think, some people are born to, or destined to have more trouble with their teeth, and I think the treatment, I'm sure it does something to affect the teeth. Certainly when people get radiation, it messes things up.
It was interesting to me that my local dentist was well aware of bisphosphonates and sent me to the endodontist who was even more well aware. So I had some work done and they said, we're not going to pull it. We'll do the root canal, we'll put a permanent crown, but we're not going to pull it because the osteoporosis will be doing.
Yeah, and so I think the dentists are more aware of it, but not all are, and it's amazing I still get patients coming to see me that they saw their dentist and their dentist said they heard they were on a bisphosphonate, so they won't touch their teeth, they won't clean them, which is like the exact opposite of what should happen. So, you know, I mean, other than telling that guy, you know, telling him, well, that may not be the best dentist. I don't know what to say. I think the problem sometimes, though, is, you know, if the tooth is bad enough, where it's loose and it's gonna come out, I think it's maybe better to just get her done, you know, in a controlled fashion than wait till it gets infected. So I've not had problems with patients have a tooth extracted if I assist with that, with antibiotics. So it's the people that, you know, get a bad tooth and they come in and their jaw, they got a, you know, like in the cartoons, they got a big swollen jaw like that, then they're in trouble because that means it's infected.
Yes.
And if it's infected, that's when you get the trouble. So I don't know, you know.
Another catch-22.
Exactly. It's hard to, maybe the dentist has an ability to predict, but yeah, I'm taking good care of your teeth, but that's expensive and, you know, again, not every dentist knows what they're doing,
Well, the
unfortunately.
endodontist I saw said that they would rather save the tooth.
Yeah, I think that's the best maneuver, if you can. If you can save the tooth, that's the preferred way of doing it.
Do you have any comments on this report?
Yeah, I'm not going to be real nice for this one, unfortunately. So Dr. Berenson and I, the reason I do multiple myeloma is a long time ago with Dr. Schiller at UCLA there was a study we were going to do using blood instead of bone marrow as a way of transplanting patients. So we were one of the first places to do that in the world. And then, as part of that, we wanted to make sure the stem cells didn't also have the mistake that the myeloma cells have, and the stem cells just produce the bad myeloma cells. And when I started my work with Dr. Berenson, well, I set out to prove, actually, that the stem cell was abnormal and, you know, matured into the bad myeloma, the plasma cells. And during that, did lots of experiments, and I think we proved the exact opposite, that the plasma cell has the cancer in it, not the stem cell, not the lymphocytes beforehand. So we proved that. The group at Toronto said the opposite. So we had this kind of head-to-head debate. And then it turns out, you know, that fortunately for that one, you know, everybody else that did the work agreed with me. So they've always thought that there's some non-plasma cell, some earlier lymphocyte that's the real culprit, and it's not the plasma cells that have the problem. And, you know, I just don't think their work is reproducible, to be very blunt. Now, I do think the concept, though, that something, you know, every drug, many drugs aren't going to work perfectly because not every cell is going to have the same abnormality. It's like we're all humans, but we all have differences. So it's the same with the myeloma cells. They all came from the same source, but there's variations. And so just by bad random chance, there's going to be, out of 1 billion myeloma cells, there may be 20 or 1,000 that may not respond, may not be sensitive to a drug. And so that's why you can't, you know, one drug usually doesn't put people in remission forever. But sometimes it can. Even with melphalan and steroids, there's people that their myeloma went in remission and 35 years later was still in remission. So, you know, it can kill every last one of them. It's just, it's hard to do that with one drug. That's why I think we use combinations. We tackle with one thing, tackle with another. You throw different things at it, makes it harder for any of the cancer cells to escape. So, yeah, that's, I guess, would be my comment to that paper.